Okay, I think a few people are still trying to work on getting logged in, but I wanted to go ahead and get started here with the ISC for Pharmacology of the Geriatric Population. Dr. Duval had asked me to do this. He's out of town covering some of the stuff for the Olympic shooters, and he'd asked me to fill in for him for this ISC session. My name's Chris Covert. Those from Mountain River know me well. Those of you from other clinics, I'm a fellow in training with the Sports Medicine of Atlanta Next Gen program. I'm working my way through all the requirements, hoping to finish up with that at the end of the year. Just a little bit of background. So today's topic is an important one as we move forward with direct access and those types of issues that we've talked about in the past throughout the residency. Some of the learning objectives I wanted to go over real quick here at the beginning. Describe the variations in pharmacodynamics and pharmacokinetic properties with aging. Develop an understanding of how pharmaceuticals can lead to frailty from a systems approach. Identify commonly prescribed drugs, their mechanism of action and intended purpose. Develop an understanding of how multipharmacy, polypharmacy, and poor nutrition impact functional outcomes, and develop an advanced knowledge of how the anatomic, physiologic, motor control, and functional mechanisms of aging are affected by drugs and may lead to frailty. So, moving forward with the presentation, what I'm going to go through first here is a PowerPoint that Dr. Duval had shared with me that he had obtained from a PhD in pharmacology that teaches some of this stuff. Now, a little bit of the material at the beginning of the PowerPoint's dated, but I think I left it in there because I think it brings up a good point of to how far we've evolved here with pharmacology and physical therapy. It's becoming more and more, you're seeing it in the entry-level programs and such. So most of you who are involved in the residency have probably had a pharmacology course, and some of these slides allude to there being a little bit of gap in knowledge and that type of thing. So hopefully with residency training coming to the forefront and this being incorporated more into the entry-level programs, this knowledge gap will be a non-issue at this point. So moving forward with the presentation here, this is coming from the perspective of a pharmacologist with a PhD in pharmacology who was lecturing to a PT program. So why physical therapists benefit from knowing some basic pharmacology, why elderly people experience more adverse drug reactions, and which medications can cause problems that affect the work of physical therapists. So what she did she did a literature search, and she found at that point in time, now mind you, this is more around 2002, she found that physical therapists can have a limited knowledge base in pharmacology, yet often our patients are asking us a lot of questions about, should I take ibuprofen? A lot of their questions hinge around, can you take over-the-counter medications with some of the prescription medications, or, which over-the-counter medication do you think might work best for me? Those types of things. So what this study found was that PTs were being asked these types of questions very frequently, and a lot of times didn't feel comfortable answering the questions. So, but like I said, I think this is evolving to where this is becoming a non-issue, and especially with residency training, I think that knowledge gap will just fade as we go forward here. So the attitude of the elderly towards PT and medications, what you'll find is a lot of older people are more likely to prefer physical means than medications to feel better. A lot of elderly people don't trust medications. They don't understand why they've been given them, or their doctor didn't really explain to them why they may be getting this medication, and it makes them feel uneasy. So that's another area where we can kind of kick in and help them. If they truly do need the medications, we can kind of tell them what the medication is and not practice medicine without a license, but at least just tell them, this medicine does this for you, this one does this, at least the name recognition to say that, this is for your blood pressure, this is for diabetes, whatever it might be. That type of knowledge can be reassuring to the patient. And then elderly are also very affected by side effects, even more than the young. So this is where they can feel disoriented, sleepy, weak. They can get things like stomach ulcers a little more easily. It can even affect their hearing impairments if that's an issue for the patient. So it's something that we really need to pay attention to as PTs and be advocating for these patients when we need to. Physical therapy has a huge role here, as we know, because these patients like to feel better through physical interaction and plus the social interaction. Some of these people are retired or don't get out much or maybe don't have the social interaction that they're used to a few years ago. So, not only that we're helping them physically, but that social interaction of getting out, coming to PT can be a lot more beneficial than just staying at home, not interacting with people, and just addressing everything with medication. It can take away their ability to feel empowered to get better and those types of things. Whereas if they're out doing something about it physically and interacting with a healthcare practitioner that shows empathy and those types of things, then they may, improve their outcome from all those total body aspects type of thing. And as you guys know from the readings, adverse drug reactions are much more common in the elderly. This chart just does a nice little summary of it. And a couple of good points that she made is if an elderly person starts a new medication and two to 3 days later they really take a turn for the worse, or they need to make a trip to the ER, or they just really have a decline in cognitive status or physical status, then you really need to take a close look if the other practitioners that are taking care of them, whether it be the ER or their PCP, you may have to advocate that somebody needs to take a look at, is this a medication issue that's really caused my patient to take a decline in status? So, these people come in and they're way different than last week or way different than last session, or they seem more confused or more lethargic or those types of things. That might be a time to take a look and really ask them some more in-depth questions about their medications, and has their doctor changed their medications, or did they change it on their own without notifying their doctor, those types of issues. So the magnitude of medication problems in the elderly is pretty huge. Patients over 65 years old were 13% of the population by the year 2000, and patients greater than 85 years old are the fastest growing segment of the population. And then this small 13% that's over 65 consumes 30% of all the drugs or medications in the U.S. So obviously it's something that we need to be paying attention to as we work with more and more of this aging population. And as the lifespan continues to increase, we're going to be working with more and more of this population that's above 65, and then probably a higher and higher percentage of this patient population over 85 who are even more vulnerable to multiple drug interactions and those types of things. And then you also get into issues where there's forgetfulness and those types of things. So then they make errors in administering the medication to themselves. So that's something you need to be aware of as well, making sure that they're taking it as prescribed and not overtaking it or undertaking it or taking medications together that don't belong together. Some of the factors here in this nice little flow chart is that as the person ages, their organ function is not quite as well, which, changes the drug concentration in the bloodstream. It's going to change the half-life of the drugs. Their blood pressure is a little more vulnerable to spikes or drops in this population. So all of these things make this polypharmacy problem much more prominent in this population. Obviously, you can have polypharmacy in any age group, but as elderly people accumulate more and more medications on their list, it becomes more and more of a prominent issue that you have to watch out for these interactions. And then as it shows in this chart, their system does not tolerate it as well. Drug absorption is normal in the elderly. It's considered normal, but their slower GI tract gives even more time for absorption. So blood flow to all the organs like the kidney and the liver, and that is reduced. So therefore, the clearance of the drug is reduced. And we can also help out with this from an exercise standpoint, because being more physically active can help them clear drug out of their system in a more timely fashion by increasing circulation, just helping them from overall blood flow and that type of thing. And then the breathing that happens with exercise as well can help with any inhaled medications that they might have, such as like an asthma inhaler or something like that. So as with most things, exercise is beneficial for this type of thing. And this is not something where you think of the benefit of exercise maybe quite as much, but it can help with this drug clearance from systemic circulation and those types of things as well. So the biggest errors made in prescribing for elderly people, once again, is polypharmacy. So that's one of the big take-home points, and this seems to be a bigger and bigger problem as these older people have more and more health problems. It seems that now it's common to just give them another medication rather than, maybe trying other means. It's just easier sometimes, I think, for the primary care physician to just give them another medication. And then sometimes when they complain about side effects, they get blown off a little bit by their doctor as just, oh, that's just old age, that's arthritis, or you're just getting older, so things are getting worse. So, you have to be an advocate in this area as well for these elderly people, because if you're seeing them more frequently and you start to get comfortable with how they do and how they function, and then they make a decline, it's easier sometimes for you to see that than their PCP. So they can get, if they call their PCP's office, the nurse might just say, hey, doc just says it's maybe aging or something like that. Whereas, if you've seen that decline in status and you know that normally they're not like this, then you can call and say, hey, well, I'm seeing this, this, and this. Do you think maybe we can take a look at their medications and see if there's something that we might be missing here? So some of the reasons that the elderly have problems taking their medications, some of them get a real fear of swallowing as they get older, especially larger pills. Their vision can inhibit their ability to read labels and information. So if they forget what the doctor or the pharmacy told them to take, sometimes they have a hard time reading it themselves. So that's where, if they don't have any help at home with those types of issues, you might have to be an advocate here as well with helping them with some of these other issues that face them on a daily basis. They may get, more fatigued, poor concept of time. They may be depressed, so they may not pay attention to what time of the day it is, especially if it's one of those people that takes a lot of naps throughout the day. They don't sleep well at night and then nap throughout the day, as some elderly people do. They may forget their medications, or they may take them at the wrong time, or they may take them too far apart or too close together. So that can affect, of course, the level that's in their bloodstream, and that can affect how likely they are to get interactions, how quickly their body can remove it from their systemic circulation, and all those types of things. So those are important things for us to be aware of as a physical therapist that's treating this population. Some of the medications that can affect our work or what we're doing with the patient, visual acuity, if it's a balanced patient, something you need to pay attention to. Is there something that's adversely affecting their visual acuity that then, by and large, after that is then affecting their balance? Is it affecting their drowsiness or mental status, their ability to remember the instructions that you give them for their home exercise program, or activities that you want them to do, or activities that you've asked them not to do? This may be something that you may have to review more frequently. and you may have to pay attention to whether medications are affecting this or not. Another issue is bruising in this population, so you may have to pay more attention to if they're on medications that can make them more likely to bruise. If you're doing interventions that are a little more like soft tissue manual therapy interventions or types of things like that, you may have to pay attention to whether they're going to be more likely to bruise and alter your interventions accordingly in regards to that as well. Some of these medications, when they interact, can also affect the vestibular system, as we know. It can drop their blood pressure. It can cause them to be anemic. It can mess with electrolyte imbalances. So all these types of things are really going to affect their performance in physical therapy. So you want to look at it from a medical screening standpoint and safety standpoint, but also is this going to affect their outcome, their prognosis? Or is this going to allow me to be effective at treating them? Are my interventions being limited by medication interactions, polypharmacy, or some of these other things like vestibular system things, maybe preventing them from improving their balance and those types of things. And then anemia from, an energy standpoint and those types of things, the patient may not feel like doing their home exercises, and that's something else that you may need to discuss with their primary care physician or whatever physician may be prescribing these drugs, and see if there's anything that can be done. There are situations where obviously they have to be on certain blood thinners and things like that from a safety standpoint. They have history of stroke and cardiac problems. So there are cases where you can't modify these things, but it's good to be aware when you can and discuss it with the physician. That way everybody's on the same page and we're getting optimal outcomes. Some of the drugs that can cause drowsiness and loss of mental acuity that can affect your PT patients: antihistamines, pain medications, muscle relaxants, anti-nausea medications, and some beta blockers. So it's good to keep this short list in your head. There are others, obviously, but these are some of the common ones that we'll see in physical therapy in our older patients that we need to pay attention to. And if they're on a conglomerate of these medications, it's something we certainly need to be aware of. Is this affecting their performance? Now, some of the issues with abdominal discomfort, constipation, inability to avoid the bladder, stomach and gastric ulcers, inflammatory bowel disease, these are some drugs that we need to be aware of. As far as pain medications, narcotics that inhibit GI motility, that can really cause constipation in any patient, but more so in the elderly. Any other medications that slow the mobility of the GI tract, like antihistamines, and then of course we know NSAIDs can lead to ulcers. The elderly are also more prone to that as well. The cancer patients that might be on chemotherapy, that really affects the cells in the GI system, and that really predisposes them to other things, such as the effects from the NSAIDs and those types of issues, because it can damage the healthy cells as well while they're undergoing that chemo. Drug-induced muscle wasting is another big issue in the elderly. Some of these drugs, this is probably the one that PTs may be a little less aware of. I know that when I was reading up on some of this stuff, that the muscle wasting was not one that popped in my head. Some of the other ones with the drowsiness and the abdominal issues and some of those you hear a little more about, but some of this stuff with muscle wasting and those types of issues are other things that we need to be aware of. Is this even allowing our patient to build up, neuromuscular control? Or are there things that are preventing them from making gains? So things like diuretics that can lower their vitamin K count, or things that can affect potassium and calcium and all these issues. Some of the beta blockers that change muscle flow to muscles can cause muscle tremors and those types of things. Some of the steroids can affect these elderly people's blood glucose. So while steroids can be a positive, for a lot of things and help with inflammation. Sometimes it can really throw their blood sugar way out of whack and really affect their whole entire system, and it may take them a while to even get their blood glucose back under control. So that's something you need to pay attention. And if you're seeing signs of that, and they have testing equipment, you may want to have them check their blood glucose and see if that is affecting their performance at that point in time. And then, of course, the heavy hitters for us are a lot of times joint pain, range of motion. So this is something where there's a lot of medications that can really affect this. So what you want to do is be aware of the most common ones, such as beta blockers, some of the statins, some of the other cholesterol-lowering agents, and then you'll see here danazol and rifampin and some of those issues. Those drugs are some of the ones that can more intensely, adversely affect joint pain and range of motion. So it's nice to have these either in the back of your mind or have a little list of some of the common ones. And if you're starting to think, is medication a factor? Is it adversely affecting this elderly patient that I'm treating? You can refer back to your list or have a little cheat sheet for yourself of some of those common drugs and say, hey, are they on any of these, or are they on any of these other ones that may interact and cause this more likely to happen? Of course, with arthritis being prevalent in this population, we have to know that they're often on NSAIDs, whether they are doing that on their own, but over-the-counter wise with ibuprofen or something like that, or is this something where their doctors prescribe them a prescription one, such as Celebrex or one of those prescription NSAIDs. And we know that some are less likely to cause these NSAID effects, but we really have to keep an eye on it in this patient population due to the factors that we mentioned earlier, with them having more predisposition due to them clearing the drug out of their system a little more slowly. So even with the over-the-counter drugs, they're going to clear those out of their system in most cases slower than the rest of the population. So bruising, like I said, this population is often, and sometimes they'll even tell you this, I bruise really easy, and you need to dig into that. And if it's a really big problem, you may have to look at some of their blood levels. You may have to get in contact with their PCP if you're going to do any more aggressive, like soft tissue treatments or that kind of thing. If they're really one of those persons that bruises very, very easy, then you may have to look at talking to their physician, whether it be the cardiologist or their PCP or whoever's managing that aspect of, the blood thinners and the anticoagulants and that type of stuff. You may need to monitor that a little more closely. So muscle relaxants, there's a bunch of them out there now, and they all work by different mechanisms. So it's good to know when your elderly patients are on muscle relaxers as well. That way, if the mechanism of action for that particular drug is known, you can look it up. And if drowsiness is a big issue, you may be able to discuss with their physician either switching them on a different one, because what seems to happen is some muscle relaxants will make one elderly patient very drowsy, and when another one may work much more effectively and allow them to get the effect that you want from a musculoskeletal standpoint and not get as much of the drowsiness effect. So, some will argue that this is not a real positive drug to give an elderly patient anyway, but we're all going to see patients that are on muscle relaxants. So at least, having a basic knowledge of their mechanism of action when it's known and which ones, you could use alternatively may help you advocate for the patient as well and say, hey, doc, if you want them on, muscle relaxant, maybe we could switch to another one that has a different mechanism of action or something that may make them not quite as drowsy and let them perform a little bit better physically. So as far as from a hearing standpoint, we know that there are some other drugs. There are some antibiotics and things like that that can really affect the elderly patient's hearing. So here's another nice list for you to keep in mind, that if an older person comes in with an abrupt hearing loss or something like that, it may be that, it's not, we don't want to just chalk it up to old age immediately and say, like, it's just, you're getting older, or maybe your hearing's getting worse. Take a little more in-depth look and say, hey, have they been on any of these antibiotics recently? So this is gentamicin is one of the most common ones that can cause these types of things. So, looking at these drugs and saying, hey, has my patient been on any of these recently, will allow you to help determine whether it was a drug interaction or something that maybe adversely affected their hearing. And, due to the issues we said with the building up in their bloodstream and then maybe not clearing drugs as quickly, even if they're taking the antibiotic as prescribed, whether it be once a day or twice a day, it may be building up more in their system than it would the average population that the guidelines were set up for. So they can build up an excess in their system, maybe more so than the middle-aged individual or the younger individual. And then looking at some of the vision issues in this population with aging, of course, we know cataracts. They can have more corneal problems and those types of things. So if your patient is having, a big problem all of a sudden that their vision has gotten worse, or they're telling you, I just can't see as well as I did last week, or, my blurry vision's really affecting my balance, it becomes a safety issue also for risk of falls and those types of things. But it's something that you might be the first person to pick up, and you need to make either whoever prescribed that medication that could be affecting their vision, whether it be cataracts or a corneal problem, you may need to get in touch with their optometrist or ophthalmologist, and also maybe whoever prescribed that drug to kind of let them tease out whether that's affecting their vision negatively, and then by and large making them at more risk of falls and those types of things. And then lastly, just to sum up here with this presentation, there are a lot of, we can't know every single drug interaction, obviously, and we can't know every single drug that causes every single side effect. But what we can do is, when we see clear signs that this may be going on, we can help the patient by their, other providers, and we can also help them tease out, are they taking their medication appropriately? Is it, staying in their system too much or too long? Do the doses need to be adjusted, or do they need to be taken off a drug or added on to another drug? So that's where we can become a real advocate for our patient.